Welcome to Sleep, Sex, and Senility, where we discuss the connection between sleep, sexual health, and brain function, and how your mouth, airway, and inflammation quietly influence all three.
Before we begin, a quick note. This podcast is for educational purposes only and does not provide medical advice. Please consult your own healthcare provider for recommendations specific to you.
Welcome to the very first ever episode of Sleep, Sex, Senility. This is a podcast created by me, Dr. Ellie Campbell, and my dear friend, Dr. Kathleen Carson. I am a board-certified family physician with over 30 years experience and over 20 years in integrative medicine. I am passionate about the fact that I believe that heart attacks are optional, strokes are stoppable, and dialysis is not your destiny. And the reason why I am so passionate is because for 10 years in my practice, I've had 0 heart attacks or strokes in any patient who follows our program. And the only way that I was able to achieve those results is when I paid attention to the most hidden risk factor for the development of cardiovascular disease, atherosclerosis, and stroke risk. And that hidden risk factor is poor oral health. Once I discovered that, the trajectory of my career changed, and I have been passionate about bringing this mission to every person that I see in my clinic, in my lecture halls, at the universities where I speak, in the book that I wrote, wherever I can share this message. I want people to know that they can be empowered to change the future trajectory of their health. So, Kathleen, tell us how you got into this.
Hi, I am Dr. Kathleen Carson. I'm a dentist and an educator with a focus on oral systemic and airway centered dentistry. I got into this because when I first started practicing, I had just given birth to my very first child. And unbeknownst to me at the time, she was born with an airway issue. She was not able to breathe well. She was not able to sleep well. She ended up with a failure to thrive diagnosis. If you want to learn more about it, I did a TED talk on this. You just need to search for Dr. Kathleen Carson TEDx and you will find it. But that started opening my eyes once we figured out that she really wasn't able to breathe properly. Because then I started looking at my patients and looking at the teeth I was restoring, the periodontal disease I was treating. And I started seeing things like chronic fatigue, migraines, anxiety, poor sleep, inflammatory conditions. And I realized that the mouth is really a larger part of the health conversation than we give it credit for. So it led me down this great path. My entire career has been focused on sleep breathing and an airway focus to dentistry, but then it took me into oral systemic inflammation and the microbiome, salivary diagnostics, neurological and cardiovascular consequences of poor oral health. And I ended up joining AOSH, American Academy of Oral Systemic Health, early in my practice. And eventually I met the fabulous Dr. Ellie Campbell. And we got to talking and decided that we should do this podcast together to bring our two minds together and help improve patient outcomes and also educate other clinicians.
Yeah, I mean, it still blows my mind. The American Heart Association just published data this week that the number one killer in our country is heart disease, is still heart disease. It's been heart disease for as long as I've been a doctor. We spend more medicine, more time, more energy, more effort on trying to prevent heart attacks, and we're not getting it. We're not cutting it. It's still, yes, heart attack deaths are down and they're going to take a little credit for that, but it's still the number one killer in our country. And it doesn't have to be. It means we've missed something. Collectively, as a health profession, we've missed something. And I truly, in my soul, believe that that thing we missed is the oral connection, because the poor oral health drives oxidative stress and inflammation and blood sugar dysregulation that are the 3 cornerstones that drive the vessel disease that lead to heart attacks, strokes, and can affect diabetes, Alzheimer's risk, cancer risk. So when we get those things under control, every part of our body gets better. And that's what this podcast is really dedicated to. So given that we've titled it Sex, Sleep, and Senility, let's start with sleep a little bit. Are there ways, Dr. Carson, that sleep is connected to our systemic health and our mouth?
Yes, absolutely. So let's go back to my daughter's story. She had an underdeveloped midface and she was born that way, and she wasn't actually able to physically breathe in a healthy manner. She was a mouth breather, not a nose breather. And what happens when you breathe through your mouth when you're young and developing is your midface doesn't develop properly. So you might get a narrow arch form, a low tongue posture, and as you breathe through your mouth, it's like leaving the window open in a dust storm. All this dirt and nastiness is coming in, it's drying everything out. And so then the microbiome in your mouth isn't healthy, and that affects nitric oxide production. So all of it adds up in so many ways we can touch on to poor quality sleep, sleep apnea, cognitive issues, even vascular issues are associated with that, as you're well aware.
Was your baby able to nurse? Did she breastfeed well?
No. You know what? And it's so interesting because I just graduated from dental school, and they don't teach you anything about this in dental school. Hopefully they do now, but back then they didn't. And no, very, very difficult breastfeeding. In fact, we had to weigh her before and after I fed her to make sure that she was getting enough nutrients. And I didn't know any better. I had no idea what was happening.
And I'll bet as a mom, you felt inadequate. I'll bet you
For
felt
sure.
like you were doing something wrong. You didn't know how to do this natural nursing thing. You weren't making rich enough milk. You were the problem. And I'll
Right.
bet you
Right.
felt that whether or not you spoke it out loud. I had 3 children that did not nurse well. What I knew then, if I knew now, then what I know now, we would have had a very different experience with our children, because I think all 3 of them have sleep disordered breathing, because my side of the family, we have very small faces. We were all told we have too many teeth for our mouths. We have to have teeth pulled to make room for all
Yep.
of the teeth, because we were born with small faces. That's not how we treat things anymore. But back
Well, and
30
that's what we were taught. I was taught that in dental school. A kid might be born with like their dad's teeth in their mom's mouth, and there just wasn't going to be enough room for him. And that's just not true. We can grow and develop properly. But yeah, when you're told as a mom that your kid's not able to breastfeed, and Ellie, that's my daughter's name too, ended up with a failure to thrive diagnosis because they literally could not come up with any other answer. And let me tell you, as a first time mom and recent graduate of a dental program, that was like a sucker punch. Like, what am I doing wrong? What could I have done differently?
right.
um and nobody had any answers, so thank goodness we have answers now,
Right. And
or at
now
least
we
some of them.
and we have ways that you can grow a baby's face so
Yes.
that you make room for the baby teeth that grow in, and then later for the adult teeth that come in. And guess what? You might not have to spend $5,000 to $10,000 on braces, because you corrected the size of their face and their mouth as infants. And
Well, and it's so important to start at that age. We were taught in school, you wait till all the adult teeth come in, but by then it's too late. So we do have to start early, and
earlier the
as a
better.
newborn.
And the number of pediatric dentists in the country pales in comparison to the number of adult dentists who take care of children. And so this message really needs to get out. And especially if you have one of those sage older dentists in your community who's been practicing for forever, they were never taught any of this. And the one
No.
thing they have to have is curiosity. They have to be curious about why that kid has a failure to thrive diagnosis, and what might I research, or where might I send that kid and that mom to get an answer to that question of why. If they're not curious enough to ask that, they go to their books and they go to their protocols, and there's nothing in there.
No, you go back to the way things were always done. But heading back to sleep, so I mean, that's one thing. If the structure of your mouth is not formed adequately or ideally for you, you actually can't breathe in healthy ways, either during the day or at night. But at night, that turns into snoring or sleep apnea, which we know causes huge issues health-wise. I mean, you can tell us more about that.
Yeah. Yeah. So sleep apnea is hugely underdiagnosed. If you carry a diagnosis of hypertension and you have not had a sleep apnea evaluation, you need to go and get checked. And I will tell you that before AOSH, I had many AOSH, American Academy of Oral and Systemic Health, before I met all these brilliant dental professionals. I got a lot of rejections when I would refer a patient for a sleep test. I would say, you need to go have a sleep test. And they would say, thank you, no, I'm not doing that. And the reason was because in their mind, if they had a positive sleep test, the one and only treatment that they were going to be subjected to was a CPAP mask. And they knew in their heart that they were claustrophobic, allergic to the paper tape, allergic to everything that they stuck on their face. If they put anything on their face, they broke out in acne. And of course, there's the whole, this is not a very romantic way for a newlywed to go to sleep at night with a mask on their face, right? So they refused because they assumed that the one and only treatment was CPAP. Now I have a different approach. I say, I would like you to do a test for sleep. It's a home sleep test. You download an app on your phone, you put an oximeter on your finger, a watch on your wrist, and a sticky on your chest. You press start on your phone. You wake up in the morning, you press stop, and within 24 hours, I have a board-certified sleep medicine specialist evaluate those data and send me a report. You didn't have to go anywhere but your own bed. And what if you have sleep apnea, and I told you I have at least 5 ways to treat sleep apnea that are not CPAP masks? Would you do this test for me? What? You have other ways besides CPAP mask? I have at least 5. We can talk about all of them when you get your test back. And now they're willing to do the test because they're not tunneled down to one single therapy.
Well, let me ask you a question too, because there's a couple of physicians that I work with in town that refer to me for oral appliances for sleep apnea. And they often want us to try that along with some of the other things like myofunctional therapy, positional deep sleeping, buteyko breathing. There's all sorts of, like you mentioned, lots of ways to help address this. But their take on CPAP, when you're really ventilating somebody, I mean, you're not teaching them how to breathe properly. So we're missing the boat there,
Right.
I think. What's your take on that?
Well, when you're desaturating, if your oxygen levels are dropping, you are choking your heart, your brain, your kidneys, your pancreas all night long, right? And so if your sleep apnea is severe, we don't really have time to wait.
Right.
I had a child once more than 20 years ago, before I was interested in integrative health, that had huge tonsils and severe sleep apnea. And I sent him to the ENT. ENT said, yep, you need your tonsils out. Back then, I don't even know that we did a sleep study. We just had a snore tape. The mom recorded an audio recording of the kids. The kid never made it to the surgery date.
Wow.
He died from low
way.
oxygen and a seizure before he was able to get his tonsils out.
That's terrible. That's terrible.
Right?
Well, and speaking of that too, because the tonsils, I mean, you hear so much, these days, people not wanting to take tonsils out, which I completely understand if there's ways to reduce the inflammation, if it's allergies or nutritional things, mouth breathing, we can help fix that. But if it's unresolved, I mean, we only have that short window of time before it can become a real problem if it's sleep apnea night after night in a developing kid, right?
Right.
So where's your line on that? What's your stance on that?
I would say a lot of it has to do with the level of desaturation. If they're dropping below 90 at night, we probably want to talk about CPAP for a short term, right? Because I hope that, because you're right, CPAP doesn't teach you anything about breathing. It doesn't strengthen your musculature. In fact, if anything, it weakens it.
But you need it sometimes, right? You need it for that initial,
to keep your oxygen levels up. The tolerability for every one patient that you refer for CPAP evaluation, I think the numbers are something like 1 in 5 will actually go and get it. And of the 5 that got CPAP machines at home in 1 year, 1 out of those is actually still using it.
The rest are in the closet, right?
The rest are in the closet, that's sitting on the bedside and collecting dust and not being used. So it's a hard therapy. It needs, and the whole idea of getting it off the internet and getting it online and getting it from, your deceased father-in-law and borrowing his, when it's not fitted for you. Women have different face shapes, sizes. There's air leaks. All these things really need to be addressed with a really good sleep medicine clinic to increase the tolerability, and lots of conversations about what are we doing? How do we make this fit and work for you, while we simultaneously work to change your airway. Do you have a nasal problem? Do you have a tonsil problem? Do you have a tongue problem? Do you have a small airway? Do we need to do a palate expander and get your face and jaw improved, because all those things can be a permanent fix.
Well, and that's the thing. It's not a one size fits all. So from like a dental perspective, I've been doing oral appliances for most of my career, well before it was, the popular thing to do. Right. But now I see a lot of my colleagues coming in and just making an appliance for every patient, but not really understanding why this person needs treatment. And so it's not always the right choice, or not the right first choice, or you need to take a design into consideration, or you need to work with co-therapy. So I think that's a problem I see right now, because I see a lot of these patients coming into my office saying, I can't tolerate this type of appliance, but it's just because the underlying cause wasn't really understood. So like expanding the palate, or treating the nasal issues, or the myofunctional therapy, or the BMI, or the hormones. There's so many things, and that's why it's so important that we work together with each other. Because I'll tell my patients, look, like OSA, if you want to think of it as a garden hose with a kink in it, CPAP is going to go up and turn that volume up on that hose and basically blast water through that kink, wherever that kink is, somewhere, if it's OSA. An oral appliance, I'm trying to like
OSA,
shake it.
Yeah.
Right. Sleep apnea. Yes. Sorry. Sleep apnea.
Because there's two primary kinds of sleep apnea: obstructive sleep apnea, where there's a kink in your hose somewhere, and central sleep apnea, where your brain doesn't tell the rest of your body to suck your diaphragm down and pull air in the way it's supposed to. And those people aren't treated the same way. They need specialized care. So we need to know, which is it, OSA or CSA? They're
or a combination, right?
Or a combination.
You can have a mix of it.
Yeah.
Yeah.
So I see too complications, right? The dentists put patients in these sleep devices, and now you see enamel wear, or you see TMJ problems, because one size does not fit all. And you have to make sure that you have a well-trained, well-educated dentist. And if you and all your friends go and you and all your friends get the same treatment, I'm going to start to wonder, while these are really one size fits many, they're not one size fits all. And so we want to be cautious that you're getting personalized precision care, and that other things are taken into consideration. When we look at a sleep test, and hopefully whoever interprets sleep tests for you, I've had a conversation with them to be sure that we're looking carefully at the respiratory disturbance index as well as the AHI. That stands for apnea hypopnea index, and that's the medical jargon that has to do with how many times in an hour are you not breathing. The RDI, we see this disturbance that your body makes. You're moving, you're gasping, you're maybe snoring, you may or may not be desaturating, but your sleep is not deep and restorative because it's being disturbed by your upper airway. And when I see that, the first thing that comes into my mind is allergies and sinus, because your entire airway should start at your nose and end at the bottom of your lungs. And when we treat sleep apnea and we start with the mouth, we're neglecting the nasal component of the airway. And so we really want to check most patients for food allergies, food sensitivities, environmental and mold allergies, because when they are present and the patient has chronic nasal stuffiness, no matter what mask you're going to put on them, they're going to have a hard time tolerating. So,
well, and let's talk about that for a minute, because breathing through your nose, so important, right? It's
noses
the
are
start
for
of your
breathing,
immune system.
mouths are for eating.
Yep. And we're making nitric oxide in our nose, and we're able to get the oxygen back down deeper into our lungs, get the exchange better. So a big part of what I do before I even put somebody in an oral appliance is exactly what you said: evaluate their nasal breathing. And we need to make sure that they're able to comfortably breathe through their nose. And if not, fix it. It's really important.
So important. And it's neglected far, far too often. And people are like, well, I don't want to do allergy tests because I don't have time to go to the allergist every week and get allergy shots. Well, guess what? I have a pack for that too.
Yep.
Right?
Yep.
Something called sublingual immunotherapy. It's drops that you put underneath your tongue. So I don't have any allergies. I'm very blessed. I don't have any allergies, but I was coming to work, and every single day I would walk through my parking lot to my office, and I would start sneezing. I'd get to the office, I'd have a morning full of sneezing, and I'd be done. Well, I did all my allergy tests. No allergies. You're not allergic to anything. But then I did a sensitivity test, and this measures immunoglobulin type G, IgG, not IgE, the typical allergy. and my IgGs to mold were off the charts. So I have a huge immune reaction to mold, but it doesn't fit the medical diagnosis of mold allergy. It's really just a mold sensitivity. So I sent all those things to the lab. They created me a custom designed drop that I put under my tongue, 1 drop 3 times a day, but I'm not good. So 2 drops in the morning, 1 in the afternoon. Get 3 drops in, but not 3 times a day like I'm supposed to. And my sneezing has cut back 90% in about 6 months.
I did the same thing. It was a blood test, right? Finger prick and send it in. And yes, so I met with
a phlebotomist in my office.
You have phlebotomist? Okay. Yeah, I don't. Lucky you. But yeah, amazing. So for me, same thing. I do have allergies though, but I'm not really good at taking that allergy medicine. I've had it my whole life. Doing the tinctures really helped me, like hardly any issues anymore. Every now and then things will flare up, but I don't have to take a daily medication anymore, having done the immunotherapy. So it was great.
Yeah.
And then on top of that though, including that, like, look at my nose. See that?
See how nasal asymmetry? See how one nostril is smaller than the other? Dentist and hygiene on the call. If you're looking at somebody's mouth and they're tipped back like that, please look at their nose.
Have them breathe in.
Asymmetry and one side is collapsing, we know they have a nasal airway problem.
Yep. So I have to open that at night. I mean, just that right there, a little coddle test. So that's why it is not one size fits all. You have to look at everything in that nasal hose.
Yep. Absolutely.
How are you? Are you doing? Are you scoping? I mean, we use CBCTs because I take them a lot in my office. But how else are you evaluating?
In practice, I don't have any scopes in my office. I guess there are a few primary care docs out there who do nasal endoscopy. I have a couple of great ENTs up the road, so we send to ENT or we send to our dental colleagues who have a cone beam CAT scan and with very low radiation can take an X-ray picture of your face that will look at your tooth roots, the size of your airway in your nose and your throat, and tell us where, if any, there's pinches that are causing obstruction in airway flow.
Yeah, we do that with all of our intake patients, and it's awesome how much you can see because you can see deviations, you can see turbinate size, you can see inflammation, you can see all sorts of constrictions all the way from the tip of the nose all the way down to however far down that image can go for you.
Right. So when it comes to sleep, we've identified that we can have a physical obstruction, we can have an allergic component, we can have central sleep apnea, we can have obstructive sleep apnea, and we have many treatments for sleep apnea that are not CPAP machines. We touched on them briefly. Myofunctional therapy, that is a type of maybe physical therapy for the jaw, lips, and tongue, right? So learn how to strengthen the muscles in our face. Dental appliances. This is another way we can pull that jaw a little bit forward. We can, over time, painlessly enlarge the size of the mid-face to make more room for the tongue so it can come forward in its natural place. By the way, the normal resting position of your tongue should be on the roof of your mouth, not on the floor of the mouth like it is in all the pictures in our anatomy classes. Yes. We can talk about nasal opening things, breathe right nasal strips or other ways to open the nasal passage. We can talk about lip taping for some people with very mild mouth breathing problems. The reason why their nose is stuffy is because they forgot how to use it. We call this nasal disuse atrophy. And so if we practice taping our lips closed while we're watching our favorite TV show, and then we can do that for 30 minutes and we don't choke. Then we do it for binge watching. And then we watch a couple of hours with our lips taped. Then we're graduated and ready to tape our lips closed at night. Once our lips are taped closed, now we've learned to rebreathe properly through our nose. And it does its job. It cleans the air. It warms the air. It gets the air deeper down into our lungs. We get higher oxygen levels at night and every part of our body benefits.
So if somebody is used to using their mouth to breathe all the time, let's say they go in and you fix that problem. You either do nasal surgery or clear up their nose somehow, use breathe right strips, use an oral appliance, whatever it is, all of a sudden they're able to better breathe through their nose, maybe where they couldn't before. They're not going to. You know, when they go to sleep, they fall asleep or they go about their day and they're not thinking about things. If they've always been a mouth breather, they're going to still be a mouth breather. Their tongue's going to be low, not at the roof of their mouth like where it's supposed to be. So even though my patients will say it seems silly sometimes to do some of these exercises, it's so important because if you don't retrain the habit, you're not going to change how you function. And then the structure is just going to relapse. And like you said, you're not going to be able to breathe through your nose again because you haven't been using it. So it clogs back up. But once you start using it, it gets easier and easier and easier and opens up more and more and more. And at least in my experience, I'd say 90% of the time through myofunctional therapy, breathwork exercises, maybe some nasal strips, some of the other like clear rinses perhaps, or the Sonu band, we can get people breathing through their nose well without surgical interventions, but they have to practice it. Otherwise, they're just going to lose it.
So testing for and treating for airway disturbances is a part of one of the many ways that the mouth is connected to the rest of the body. I'm Dr. Ellie Campbell.
And I am Dr. Kathleen Carson.
And we are honored that you joined us on this podcast today.
Thank you for joining us on this episode of Sleep, Sex, and Senility. For more information, such as show notes, links to anything we talked about, and other episodes, please visit us on our website at sleepsexandsenility.com. We look forward to seeing you next time.
Nanoverse Media, making the world smaller.